Welcome to the Deep Dive. We're here to really extract the essential insights from important sources, making complex topics accessible fast.
That's right.
And today, we're diving into some really fundamental stuff. The pathophysiology behind disorders of thought, emotion, and memory. Our source. It's Chapter 18 of Porth's Essentials of Pathophysiology.
Yeah, and our goal here is pretty straightforward. We want to walk you through the key mechanisms, the core concepts, and some clinical examples directly from this chapter.
Think of it as getting the blueprint. Understanding how the brain's structure and its chemistry can sometimes, well, go off track, leading to issues with behavior and thinking.
Exactly. We're charting that terrain where brain meets behavior.
Okay, so let's start with the scale of this. Because the numbers in the chapter, they're pretty striking.
They really are.
We're looking at a 17.9% prevalence of mental illness among U.S. adults alone. But this really stood out to me. 50% of all chronic mental illness actually starts before age 14.
Half. Before high school, essentially. And, if you link this to physical health, the connection is incredibly strong. The chapter notes, 30%?
Yeah, 30% of people who have a physical disorder like diabetes, heart disease, they also have a coexisting psychiatric disorder.
It shows just how interconnected these systems are. You can't really separate mind and body when you look at it pathologically.
Definitely not. So, okay, to understand that connection, we need to look at the building blocks. What are the main contributing factors the chapter points to?
Well, it breaks it down into three main categories, which usually interact. First, you've got biologic factors. That's things like genetics, maybe infections, exposure to toxins, brain injury.
Right. The physical hardware, so to speak.
Sort of, yeah. Then there are psychological factors, things like chronic stress, significant loss, or maybe neglect, especially early on.
Okay.
And finally, environmental factors. This could be substance use or maybe really dysfunctional family dynamics. The main point is it's rarely just one thing. It's usually a mix.
And this is where the stress-diathesis theory comes in, right? Which feels like a really core concept here.
Absolutely core. It's the model explaining how that biology, the diathesis, or our inherent vulnerability clashes with our environment, the stress.
So talk about adverse childhood experiences, or ACEs. The chapter links these experiences to some pretty serious long-term physical costs.
Yeah, ACEs, we're talking about things like neglect, abuse, serious household dysfunction. They are linked to really profound, measurable physiological changes down the line.
Measurable how?
Well, for instance, high levels of inflammation. Specifically, the chapter mentions high-sensitivity C-reactive protein, levels over 3 milligl. Yeah. And having those high levels associated with ACEs actually doubles the long-term risk of heart disease.
Wow. Doubles the risk. That's a direct physical link from early psychological trauma. So how does that happen? How does that early stress physically change the brain or DNA?
The key mechanism discussed is methylation. Basically, prolonged stress, particularly in childhood, chemically modifies the DNA. Think of it like this. Trauma can put these molecular clamps on certain genes, specifically the genes that are supposed to help regulate your response to stress hormones.
So the brain can't turn off the stress signal properly.
Exactly. It becomes less efficient at managing stress hormones like cortisol because the underlying genetic machinery, how it reads those genes, has been physically altered by the early experiences.
And if that fundamental stress system is altered, I imagine that messes with the brain's ability to adapt and change neuroplasticity, especially around traumatic memories.
Precisely. A lot of psychopathology involves this kind of dysregulation disrupting neural networks. When you experience something intensely emotional or stressful, your amygdala, that's your brain's sort of emotional alarm center, it flags that memory as important, strengthens the imprint.
Okay.
But if the stress is overwhelming, the prefrontal cortex, the part responsible for rational thinking, planning, integrating memories, it gets sort of bypassed or overwhelmed. It's less likely to process that memory in a coherent, logical way.
So that difficulty, that inability to really process and file away a traumatic event, does that show up structurally? Can you see changes in the brain?
You can, yeah. Research highlighted in the chapter shows that in individuals with significant trauma histories, the actual size of both the amygdala and, critically, the hippocampus can be reduced.
And hippocampus is key for memory, right?
Key for explicit memory, the conscious recall of facts and events. So this structural damage makes it physically harder to weave those traumatic memories into a coherent personal narrative. The story remains fragmented, intrusive.
Okay, so since structure and memory types are so linked, maybe quickly define the types of memory the chapter outlines.
Sure. It classifies memory by duration. Immediate is just seconds or minutes. Recent memory lasts minutes to days. And remote or long-term memory involves years and actual structural changes in the synapses.
Got it.
And then functionally, there's implicit memory that's unconscious stuff, like skills, habits, emotional responses. And explicit memory, which is your conscious recall of facts, events, knowledge. That's the one really impacted by hippocampal damage from trauma.
Okay, so structure, trauma's impact. Now let's talk about the chemicals, the messengers. How do neurotransmitters fit into this picture of stress and behavior?
Right, the neurochemical piece is huge. We can run through the key players mentioned in the chapter, often summarized in tables like Table 18-1 for those following along with the text.
Okay.
First up, dopamine, DA. Super important, involved in reward, motivation, judgment, even involuntary motor movements. Its dysregulation is implicated across a huge range of disorders: schizophrenia, mood disorders, anxiety, and definitely substance use disorders.
Yeah, dopamine and reward, that makes sense for addiction.
Yeah.
What about the ones people often associate with mood, like serotonin?
Yeah, serotonin, 5-HT, and norepinephrine, NE, are classic players, especially in mood disorders and anxiety. 5-HT is crucial for regulating sleep, appetite, mood. Imbalances here are a major focus.
Okay. But don't forget the amino acids. GABA is the main inhibitory neurotransmitter. It sort of calms things down. Deficits in GABA activity are linked to schizophrenia, mood disorders, anxiety, even neurocognitive disorders.
So less GABA means more excitability, potentially more symptoms.
Generally speaking, yeah.
Right.
And its counterpart is glutamate, the primary excitatory neurotransmitter. It's about balance.
And is this chemical soup, this balance or imbalance, ultimately tied back to that stress system we talked about earlier, the HPA axis?
Absolutely. It's all connected. The hypothalamic pituitary adrenal HPA axis is the central command for the stress response, regulating hormones like CRH and cortisol.
Right.
The chapter emphasizes that trauma, especially early trauma, fundamentally disrupts the regulation of this axis. You often see chronically high cortisol levels in conditions like depression, which contributes to the pathology.
Okay, that connects a lot of dots. So let's apply these foundations now. Let's talk specific disorders, starting with schizophrenia. What are the core features? Schizophrenia, it affects about 1% of people. The core seems to be a breakdown in how the brain processes reality, maybe a failure in filtering information. Diagnosis usually requires at least 2 major psychotic symptoms for about 6 months.
And those symptoms fall into categories, right? Positive and negative.
Exactly. Positive symptoms aren't good symptoms. They're the presence of abnormal things. Think hallucinations, especially hearing voices, delusions, fixed false beliefs like paranoia or feeling you have special powers, and disorganized speech, maybe using made-up words, neologisms, or just jumbled speech, word salad.
So those are the additions. What about the negative symptoms? You mentioned they could be tougher to treat.
Yeah, negative symptoms are the absence or reduction of normal functions. They often cause more long-term impairment. Things like alogia, which is speaking very little, avolition, a real lack of motivation, affective flattening, where there's very little emotional expression, and anhedonia, the inability to feel pleasure.
That sounds incredibly debilitating.
It is. And you can also see disorganized behavior, like maintaining odd postures, sometimes called waxy flexibility.
So connecting this back to the neurophysiology, what's going wrong chemically and structurally?
It's complex, likely multiple hits, definitely dysregulation in the dopamine system, but also the serotonin system. There's evidence for decreased glutamate activity, particularly involving the NMDA receptor, and deficits in GABA in key brain areas like the prefrontal cortex.
And structurally?
Structurally, studies show a loss of cortical gray matter over time and enlargement of the brain's ventricles, the fluid-filled spaces. It suggests some neurodegenerative component.
Okay. Let's pivot quickly to mood disorders. Major depressive disorder, MDD.
Right, MDD. Key features are persistent low mood or loss of interest pleasure, plus other symptoms like changes in sleep, appetite, energy, maybe suicidal thoughts lasting at least 2 weeks.
And the pathophysiology there.
The chapter points to things like low levels of brain-derived neurotrophic factor, BDNF, especially in the hippocampus. BDNF helps keep neurons healthy, and again, strong links to chronic inflammation and that dysregulated HPA axis high cortisol.
And the other side of the coin, bipolar disorder.
The hallmark of bipolar disorder is mania periods of abnormally elevated, expansive, or irritable mood, high energy, racing thoughts, risky behavior. This alternates with episodes of major depression.
Are there different types?
Yes, primarily bipolar 1, which involves full manic episodes, and bipolar 2, which has hypomania, a less severe form of mania, plus the depressive episodes. Pathophysiology points to impaired neuroplasticity and issues in brain regions regulating emotion, like the subgenual prefrontal cortex.
And lithium is mentioned as a key treatment.
Still considered a gold standard, yeah. Helps stabilize those mood swings.
All right, let's tackle anxiety disorders. The chapter notes these are the most common psychiatric disorders overall. What stands out about their presentation?
Let's focus on, say, panic disorder. It's characterized by these sudden, unexpected surges of intense fear or discomfort.
Right.
And the physical symptoms are often overwhelming: heart palpitations, shortness of breath, chest pain, dizziness, nausea. People genuinely feel like they're dying, often like they're having a heart attack.
Which explains why they often end up in the ER.
Exactly. And interestingly, the chapter links early life experiences, like trauma or even severe separation anxiety, as risk factors for developing panic disorder later on.
And chemically, what's the engine driving a panic attack?
It seems to be an underactivation of the calming serotonin system, combined with a massive overactivation of the adrenergic system, the sympathetic nervous system, your fight or flight response.
So the alarm system is just going haywire.
Pretty much. Brain regions like the amygdala, the limbic system, and parts of the prefrontal cortex become hyperactive in this loop, creating intense fear without a proportional external threat.
Okay. And briefly, obsessive-compulsive related disorders and substance use disorders.
Right. So OCD and related conditions like body dysmorphic disorder or hoarding, they're now separate from anxiety disorders in the DSM-5. Pathophysiology points to disruptions in circuits involving the orbitofrontal cortex, cingulate cortex, and basal ganglia areas involved in habit formation and error detection.
And SUDs, substance use disorders.
The core issue there is the hijacking of the brain's reward system, heavily involving dopamine. It creates this powerful drive to seek the substance. Genetics play a big role too, maybe up to 50% heritability for addiction.
The chapter uses alcohol as an example.
Yeah, alcohol boosts dopamine release indirectly through interactions with glutamate, GABA, and endorphin systems. Chronic heavy use, though, can lead to severe neurological damage, like Wernicke-Korsakoff syndrome, a profound memory disorder caused by thiamine, vitamin B1 deficiency.
That devastating consequence really brings us to our final category. Neurocognitive disorders, or NCDs, the term replacing dementia. What's the absolute key difference between NCD and just normal aging?
This is critical. NCD is not normal aging. Everyone slows down a bit as they get older. Maybe learning takes longer, processing speed isn't quite as fast. But with normal aging, your day-to-day functioning, your independence, remains intact.
Yeah.
NCD involves a significant decline in cognitive function, memory, attention, language, judgment, that is severe enough to interfere with daily activities and independence. That's the line.
And the most common NCD by far is Alzheimer disease, right?
Correct. AD accounts for maybe 60 to 80% of cases. It typically has an insidious onset and progresses over, say, 8 to 10 years on average.
Let's focus on the defining pathology. What are the microscopic hallmarks everyone needs to know?
Two key things, absolutely crucial. First, neurofibrillary tangles. These are found inside neurons. They're made of an abnormally chemically modified protein called tau. Normally, tau helps stabilize the neuron's internal skeleton, but in AD, it gets hypophosphorylated, clumps together, and disrupts the cell's function from within.
Okay, tangles inside the neurons. What's the second hallmark?
The second is amyloid plaques, sometimes called neuritic plaques. These are dense deposits found outside the neurons, in the spaces between cells. They're primarily composed of a sticky protein fragment called amyloid beta, or ALAPE.
So sticky junk building up outside the cells.
Essentially, yes. It's thought to result from an imbalance between the production and clearance of this peptide. These plaques disrupt communication between neurons. And over time, this pathology, the tangles and plaques, leads to widespread neuron death and significant brain shrinkage or atrophy, especially in areas vital for memory and thinking, like the temporal and parietal lobes. Decreased cholinergic transmission is also noted.
Got it. Tangles inside, plaques outside. Can we quickly touch on the other NCD subtypes mentioned?
Sure. Delirium is important to distinguish. It's an acute, sudden onset, fluctuating state of confusion. It's usually caused by an underlying medical issue like an infection, medication side effect, or severe pain. It's often reversible if the cause is treated.
Okay, acute and often reversible. What else?
Vascular NCD is caused by problems with blood supply to the brain, like multiple small strokes or damage from chronic high blood pressure. The pattern of cognitive decline often depends on where the damage occurs.
Right, Sam.
Then there's Lewy Body Disease, LBD. This involves abnormal protein clumps called Lewy bodies, made of alpha-synuclein, accumulating inside cortical neurons. Key features often include fluctuations in attention and alertness, recurrent visual hallucinations, and Parkinsonian motor symptoms like rigidity or tremor, often appearing relatively early.
So it can look a bit like Parkinson's and Alzheimer's combined sometimes.
In some ways, yeah, it shares features. Finally, Huntington disease, HD. This is a genetic disorder caused by a specific gene mutation. It leads to degeneration in the basal ganglia, particularly affecting GABA neurons. This results in excessive glutamate activity and causes the characteristic involuntary jerky movements called chorea, along with cognitive decline and psychiatric symptoms.
Okay, wow. We have really covered a huge amount of ground here, from the foundational interplay of genetics, environment, and trauma.
Yeah, how things like ACEs can physically change stress regulation through epigenetics like methylation.
To the specific roles of key neurotransmitters,
Yeah.
dopamine, serotonin, GABA, in conditions like schizophrenia, depression, anxiety.
And finally, to the structural pathology, the plaques and tangles in Alzheimer's or the Lewy bodies that define neurocognitive disorders.
It's incredibly complex, but understanding these underlying mechanisms feels crucial.
It really is, because if you understand the pathophysiology, the how and why these conditions develop, as outlined in the chapter, it shifts the focus. It helps us think about identifying who might be vulnerable and maybe how to build resilience.
Which leads us perfectly to our final provocative thought for you, the listener. Given everything we've discussed, especially the chapter's emphasis on epigenetics and how adverse childhood experiences can seemingly permanently alter DNA methylation and the brain's stress regulation systems, what kind of preventative, maybe community-wide interventions do you think might offer the greatest potential for actually reducing the lifetime prevalence of serious mental illness by tackling those early life adversities?
That's a really powerful question to ponder. What can we do upstream?
Indeed. Well, thank you so much for joining us on this deep dive.
Thank you.
We genuinely hope breaking down this chapter from Porth's Essentials was helpful and maybe saved you some time while getting you well informed. We'll see you on the next deep dive.